Before we begin the sessions, I would like to invite back to the stage Her Royal Highness Princess Dina Mered, who is the President-elect of the Union for International Cancer Control. There's a little bit of unfinished business that I think she needs to take care of. Your Royal Highness.
Hello again, I'm back. We found the missing slide for the board members of City Cancer Challenge team. And I think we are so proud. You need to know who are the board members because they're going to be taking up a very important initiative, the City Cancer Challenge, and we're very proud to have the first board. So I'd like to read out. The chair will be Dr. Sanchia Aranda, Cancer Council Australia, and our very own current president of UICC. The vice chair will be Dr. Raul Doria, Grupo San Roque, Paraguay. The board members are Zipporah Ali from Kenya Hospices and Palliative Care Association, Kenya. Thomas Cueni from the International Federation of Pharmaceutical Manufacturers and Associations, Switzerland. Mary Gozdarovic, sorry Mary, I always get stuck with your name. Princess Margaret Cancer Center, Canada. Yin Yin Tun, Shui Yong Nin Si Cancer Foundation, Myanmar. Colleen Kennedy, Varian Medical Systems, USA. Mark Middleton, Icon Group, Australia. Jorg Michael Rupp, Roche Pharma International, Switzerland. Luis Miguel Castilla Rubio, Inter-American Development Bank, USA. Adolfo Rubenstein, National Ministry of Health, Minister of Health, Argentina. Please give them all a big round of applause. We wish this board member all the best, and we as UICC will remain supportive to make sure that this initiative continues to deliver on the ground. Thank you very much.
Thank you, Your Highness. Can I invite Dr. Paula Vivili, please, up to the stage? Dr. Vivili is the director of the Public Health Division of the Pacific Community, and he's going to tell us fascinatingly what is going on in the Pacific Islands. Paula, welcome. Have a seat, please. I say that because the Pacific Islands present a completely unique set of challenges, I think, don't they? 25,000 islands across a vast sea, a third of the world. How do you begin to organize cancer control in this place?
Well, thank you very much, Your Royal Highnesses, Excellencies, ladies and gentlemen. First of all, I'd just like to thank the organizers for inviting us from the Pacific to be here. One of the unique things about the Pacific is, I would say particularly for this audience, is many of you don't know very much, if anything, about the Pacific. So we look at this as a great opportunity to be able to have some discussions about our region. Before the meeting, we were asked specifically not to bring a slide. But I asked very nicely if we could just have one slide, just to give some background, because I think without the background to the region, the discussions will be a little bit difficult. The Pacific is made up of 22 Pacific Island countries and territories, populations ranging from just over 1,000 to just about 9 million for Papua New Guinea. Health budgets that make up about 10 to 15% of the recurring budgets of the government. So you could say that the governments are giving a good proportion of the money into health already. Non-communicable diseases is the biggest burden of disease, accounting for, depending on where you come from, 60 to 70% of mortality. Some work has been done in the region and has found that, in fact, while the life expectancy is increasing in most countries in the world. In the Pacific, it seems to be either plateauing or decreasing in some countries because of the impact of non-communicable diseases. Because we are low middle-income countries, by and large, it's still cardiovascular disease, as you saw from Freddie's talk earlier. But we are also seeing cancer becoming increasingly important.
So let's just start with the numbers, shall we? Because it's kind of unclear to, I'm sure, everybody in this room, including myself, who doesn't know the Pacific Islands either, what the burden of cancer is across the region, and how do you actually estimate that burden, given that there aren't really very robust data sources?
Well, the easy answer to that is there's not much information, particularly from countries. And just to give you an idea, not very many countries in the Pacific would have a robust cancer registry that we can go to very easily to look at some of the work. So in recognition of this, the IARC and some of the partners in the Pacific are looking into setting up a Pacific hub for cancer registries, primarily to look at addressing this data gap and how we can bring up more information. So GlobalCan, for instance, extrapolates a lot of the information for the Pacific. While there is some limited information, it's actually difficult to get accurate information. If you're looking at the types of cancer that you see, by and large, you see most cancers in the Pacific would be breast, cervical cancer, lung cancer, and for men also prostate. One of the interesting things in the Pacific as well is the geopolitical alignments and affiliations. And for example, thyroid cancer, you see cases of this in the countries where there was some nuclear testing early on, particularly from the French and US. And the geopolitical component also impacts what we're able to do about these things. For example, by and large, you find that in the Francophone countries, namely New Caledonia, French Polynesia, and Wallis and Futuna, access to information and treatment is much better. Similarly, for countries that have affiliations with New Zealand, Cook Islands, Niue, and Tokelau, access again is there. But for independent countries who are on their own, it is rather difficult for them to address these things. I mean, to give you an idea, these are small populations. Health expenditure per person would be, on average, about $200 US per person per year for a small population, not for big population. So there isn't, in terms of absolute amounts of money, there isn't much to go around. So the issue of data information and surveillance is something that needs to be, as you can appreciate, a lot of people die from cardiovascular diseases.
Obesity is
a big problem. The Pacific often is known as the NCD capital of the world. Because if you look at the top 10 lists for obesity, for example, in diabetes, most, if not all, of the countries are from the Pacific. It's not something we're proud of, but certainly something that we're very keen to address. And one of the good things in the region is that the leaders have really committed to addressing these things. But they've agreed to do it in a staged approach. Many countries, for instance, they can't do dialysis, they can't do coronary artery bypass, complicated diabetes, ophthalmic conditions cannot be treated locally. So if you put cancer in that context, perhaps it might make sense that to date, we haven't really been able to address some of the challenges, although perhaps this is the right time because of all the commitments and all the things that have been done to date. It's a good time to be looking at the things of how to progress things forward.
And of course, you mentioned diabetes and obesity, but some of the challenges around the comorbidities that exist in that in Papua New Guinea, the confluence of those with tuberculosis is a very serious problem, and I'm sure that there are comorbidities around cancer as well. Just to try and sort of understand and picture the way in which patient pathways evolve in cancer in the Pacific Islands. How would a typical patient pathway around cancer look?
It depends on where you are.
Yeah.
So it will range from the countries where I alluded to have pretty good support. So you would present to your hospital and you will get pretty good diagnostic care. and then you will get pretty good treatments, and at the later stages get pretty good palliative care. It would be fair to say that that's the exception more than the norm. At the other extreme, you have a patient that would present to the hospital with cancer and would be told that nothing can be done. Less than half the countries in the Pacific, for instance, would have a qualified pathologist. So then gives you an idea of the context. Even diagnosis is a challenge. But many countries are moving into a stage where they're wanting to do some limited treatments. So, for example, there are some partnerships with Australia and New Zealand where there is support provided, and the countries send the patient, for example, to New Zealand, where they get the initiation phase of chemotherapy, and then they come back to the countries in the Pacific to continue the treatment. And even some of the countries are looking at going on towards treatment in cancer. If you go back to the preventive side of the spectrum, one of the things that Pacific countries are very proud of is they have very, very good immunization rates by and large. So when you're putting up indicators, we're not very proud of obesity and diabetes. But when we talk about immunization rates, in many countries in the Pacific, there's 95+% completion rate. And so the discussions around hepatitis B, for instance, hepatitis B vaccination rate for many Pacific countries is very high. And this provides an opportunity for us when we're considering HPV, for instance. Cost is still an issue. Yep. In our 22 Pacific Island countries and territories, there'll be about 6 countries that currently have HPV as part of their normal immunization schedule, primarily because of cost. But increasingly, more countries are looking into how they can provide some support. So if you're looking at the continuum from prevention to treatment to palliative care, depending on where you are, it would be different. But by and large, it's a struggle for many of the countries.
And you represent the Pacific community, and I wonder how the community puts itself together in terms of the development of cancer control and cancer control plans. What is the status? I mean, obviously countries like New Zealand have cancer control plans, but do all of the countries of the Pacific region have cancer control plans? What state are they in, and how are you moving that forward as a collective, and what role and to what extent is it a collective, and to what extent is it run by the countries themselves?
So most countries would not have a cancer standalone plan. Most countries would have an NCD plan. And so a lot of the work has been to try and align the cancer work into the NCD work, because risk factors and then a lot of the issues related are similar. We have very good support from partners, Australia, New Zealand, France. IARC, as I alluded to earlier, has now come in to help the Pacific do some of the work around surveillance and cancer registries. The WHO is a very important partner in the Pacific in doing some of the work. We like to see the work in the Pacific as being a two-pronged approach. One is where we have regional approach, and in the regional approach, we as SPC work with partners. The work on cancer actually is a lot of the work is led by WHO. We work very well together to help the countries into how we want to put things together. So the notion of this Pacific Cancer Hub that we're discussing this week with IARC and other partners is an attempt to strengthen the regional approach, where we can have some of the work come together, and then we see how we, from a regional perspective, we can give some support. And the other notion is doing it more at a national level, where the capacity and capability of the different countries are different, and some would be more capable to do the work compared to others. And then from the regional approach, we see how we can complement some of the good work that's happening, and perhaps addressing some of the gaps that are there to make things happen. So in terms of planning and policies, we're looking at putting things together to address these issues and taking it forward. One of the interesting things in the region as well is the notion of using health finance as a stimulant or catalyst for action. In the Pacific, we have a Pacific NCD roadmap, and its genesis was from the World Bank doing a presentation for Pacific finance ministers. And Pacific finance ministers looking at the cost and the implications of non-communicable diseases directed SPC, WHO, and the other partners to put together the roadmap. But again, it's because of using, so the importance of information, not just in surveillance and cancer information, but using finance. also as an important aspect of this is very important. And so looking at going ahead, it's one of the things important to look at.
And you say, obviously at the moment, many countries have quite high expenditures on healthcare in relation to their GDP, but actually the reality, of course, on the ground is that most of that, relatively it's quite small, and that actually treating cancer, preventing and treating cancer is quite a challenge within those circumstances. What do you think the role of advocacy groups, other groups outside of this in pushing health ministries as well, indeed, pushing finance ministers to really understand the challenges that are faced with them, the economic and other challenges that are faced as a result of not treating cancer or not addressing it in the long term, and how are you beginning to build that? I know here, regionally, at this event, you have a number of meetings set around the regional context of it. How are you beginning to address that?
So just to have a discussion on finance, the growth of non-communicable diseases is quicker than the growth of the economies in the Pacific countries, which means that although the countries are already contributing a significant component of their money to health, it will always lag behind the actual cost of disease because the growth of the economy is slower than the growth of the diseases. Yeah. So I think on one aspect, we have to be pushing the government to be conscious of the fact that because most Pacific health systems are fully funded by governments, very little out of pocket, in terms, at least for treatment of cancer and the complications of NCDs. It's important for us to be realistic about what the governments can do. Yeah. Already they're contributing a lot. Economic growth is not very great, and so the real growth in the money that they're able to give is limited. Mm-hmm. And this is why I think it's important in a forum like this to be looking at partnerships. And Australia and New Zealand are doing a lot of work. Japan's doing some work in countries where they're specifically looking at areas where they feel that their contribution can make a difference. And as time goes on, we're seeing more and more people being interested in cancer. IAEA, for example, has come to the region and had a look at what potentially they can do. So it's looking at the governments themselves, I think, is a model that may be doomed to fail because of the reality of the economics. But if you're looking at the partnerships and developing work relationships with other people who have a strong interest, matched with the passion of the Pacific countries who want to do more within their means, plus perhaps what they're able to get from others, we have some hope of taking things to a better place.
So let's talk about the better place. Given that, there is a set of challenges around equity of access, around affordable access to cancer treatment and care in the Pacific Islands. What do you feel are the most important next steps for both the Pacific communities and individual countries to be taking?
Just a very quick one about context again. In my country that I come from Tonga, the furthest island away from the main capital is closer to Samoa, which is the next country than it is to Tonga. It is cheaper to fly to Australia or New Zealand than it is to fly to these outer islands. And so you have this, when you're talking about inequity, it's a very real issue for Pacific countries.
And there are other countries as well, that India, Thailand, where those people can afford to go to those countries will take.
And so, notwithstanding whether you can afford treatment, just to afford to front up to where you need to have the test, which often may not be available, is an issue. I think going forward, it needs to be a very multi-sectoral approach, and I know it's a cliche, multi-sectoral work, everybody talks about it. But in the Pacific, where the resources and the capacity of the countries are very limited, it is the only way forward. Even when you look at multilateral partners in the region, in the Pacific, because we're so small and the challenge is so big, they have no choice but to work together. So by and large, you find in the Pacific, the working relationship between multilateral partners, WHO, World Bank, ADB, and Australia and New Zealand, very, very good. And so this actually puts a very strong focus on what needs to be done. As I mentioned earlier, one of the things we look at is strengthening the regional architecture. And we have a very strong Pacific Health Ministers network that meets every other year. And in fact, they we'll be approving the work that we're doing on the hub that we'll be discussing here next year. It's gone through the Pacific Heads of Health, which is the CEO forum. So when we strengthen all the regional networks, take it through to the ministers, it gives us the ability to go and say we've got the political commitments. And then we look at the countries and how we can do that. One of the things that we've been very pleased at having time to have a discussion here is that many people probably have no idea about the Pacific. I've met a few people that ask, where are you from? I'm from Tonga. They say, where's that? Yeah. And so if they don't know where many of the countries are, you can imagine how much they know about cancer control and prevention in the Pacific. Yeah. And so one of the things, I'm sure there are people in the audience who are interested at perhaps talking about some of the things that we can do. Perhaps there are some people in the audience who have too much money. And, the idea of adopting a Pacific country and looking with regards to the cancer work.
Any adopters here?
I mean, and one of the things we see a lot of discussions and commitments, and we need to do this, Yeah. It's a small country. Your contribution and commitment may not be as big as you have to do in many other places. So hopefully when we come together in a few years, we can come together and say, the dude who came and talked about the Pacific, we've actually done a bit of work in one of the 22 countries. Some progress.
Well, I hope this conversation is awakening everybody in this room to the fact that the Pacific Islands are there, they're complex, and they need attention, and they need a set of multi-sectoral partners that are really interested in and capable of helping in those situations. I certainly know in Papua New Guinea, where I was recently at the APEC health meetings, the challenges that are posed by addressing cancer, let alone against all the other priorities, are really, really great. And I think that must, certainly in smaller Pacific islands, that must be a real problem. But Paula, thank you very much. Really appreciate those thoughts. Thank you. Let me... Paula is going to remain on stage, and I'm going to invite up to the podium our four next panelists to bring the discussion to, let me just get my notes, to the importance of multi-sectoral arrangements. Could I ask the panelists to come up to the stage, please? Let me just introduce them. Dr. Firas Raad, who is the World Bank Country Manager for Malaysia, formerly in Kuwait. Dr. Anil de Cruz, who is the Director of the Tata Memorial Hospital and a UICC board member. As you come up, let me just... Anil, thank you very much. Firas, thank you, nice to see you. And Thomas Cueni. Eamonn Murphy, thank you very much indeed. Do please sit down. We are now going to have a sort of extending this discussion that Paula and I have, a sort of more rounded discussion around the whole question of multi-sectoral approaches. And I want to begin, if I may, with a perspective from the World Bank, just so that we can try and understand from a multilateral organization's perspectives the thoughts around cancer and cancer control.
So thank you, Charles, and allow me to extend my thanks to UICC, to Princess Dina, and Carrie for the kind invitation. And I'm delighted to represent the World Bank at this important event. Although I left the health sector and being involved in it directly, as I am now in charge of the World Bank program for Malaysia, it's still a sector that is very close to my heart, and my training has been in health all along. And more importantly, for those of you who know Princess Dina, she's the type of person who does not take no as an answer. So when I was contacted by her, she gave me an answer or an offer that I could not refuse, and so I am delighted to be here. Let me just share, Charles, a few thoughts from our perspective in the bank in answering your question. So I think first off, as we heard from Dr. Bray, NCDs and cancers, that burden is on the rise. And this epidemic, if left unchecked, will have a tremendous impact on governments, their budgets, companies and households. And this growing epidemic is driven by a few mega trends: population aging, urbanization, changing lifestyles, and so forth. Second, the impact of this epidemic will disproportionately affect the vulnerable populations, the poor in the lower and middle income countries. We know that about 70% of NCD deaths are in these countries. And what we have seen is this vicious cycle between disease and poverty. And if you are subjected to disease and have to pay a catastrophic health payment, you can slip into poverty or near poverty very quickly. In fact, a large longitudinal study here in Southeast Asia showed that about 37% of cancer patients have to make these kinds of payments and fall into a vulnerable status. Thailand, within that study, fared pretty well. I think the number was about 16%. In Malaysia here, in fact, it was about 45%. In Kenya, for example, we know that stage 3 treatment costs for some cancers, cervical or breast, could run up into the thousands of dollars, and that's beyond any household budget. But there are things that we know that work. There are cost-effective interventions. WHO and others have highlighted them. And these are the best buys in tobacco control, vaccinations for liver and cervical cancers, and the promotion, I would add, the promotion of healthy living overall. Fourth, and this is quite clear, that coming out of New York, we have seen that the world is not doing what it should be doing. I think we are slipping behind, and business as usual will not work anymore to try to reach the targets that we set for ourselves. So according to a series of Lancet articles, about 30 to 35 countries are on track to meet the 3.4 SDG by 2030, but there are a whole host of other countries that may meet it, but with a little bit more intervention and effort. And I think the question for all of us is, how do we support those extra batch of countries, the second batch, and then beyond them, the other 100 countries that make up the rest of the world. Fifth, I think addressing the NCD epidemic, and this has been mentioned by everyone, requires really a scaling up of our holistic and multi-sectoral interventions. And I would just highlight 4. I think reducing risk factors, tremendous amount of effort should go into reducing these factors: tobacco, alcohol, unhealthy diets, and physical inactivity primarily. Investing in screening and early detection, and then looking into treatment very carefully. And I would then highlight what was highlighted before. Princess Dina, in her speech in New York, focused on the whole of government approach. The whole of cabinet should be taking on this challenge and cannot be left only to the Minister of Health and the health policy makers. I think that is tremendously important. The use of fiscal measures in the bank, we try to promote certain levers related to taxation. I think much more can be done in that respect. And we've seen innovation and partnerships with the private sector, government, private sector, NGO, civil society coming together and promoting certain innovations like the solidarity tobacco contribution. Lastly, Charles, I'd just like to mention that I think international comparisons can spur policy action on the ground. We will be coming out with a ranking in 2 weeks' time during our annual meetings, a global report ranking countries in terms of human capital outcomes. And we're hoping that that will spur a lot of the leaders, the policymakers, to invest a little bit more in improving health outcomes in their countries. So thank you very much again for the invitation and the opportunity to participate.
Thank you, Firas. I'm a warm thank you. I mean, one of the, and since you're representing the World Bank, I think it's appropriate just to sort of focus a little bit on the financing side of it and the challenges that are raised by paying for some of the things that you were talking about in many countries. What is it that you are able to do for countries in terms of helping them put together the thinking behind financing cancer control? What is it? And obviously we're talking about a wide spectrum of countries here, but let's say lower income countries. Where do you position the thinking around financing? What is it that finance ministers and health ministries really need to understand? And outside of that, you mentioned also the possibility of there being public-private partnerships around financing. Where is that leading countries? To what extent is supplemental private financing important for cancer control, do you think?
So on this issue, maybe I'll highlight a few points. I think it's critical for countries to, A, know what they're spending on, and sometimes the data is simply not there. It is sort of fragmented. So you could have ministries of health, the army, the universities, and so on, private sector spending, but there's really no accurate snapshot of what is being spent on. And I think there, the World Bank, others can help support them with that kind of process. So once you have a baseline, you get a sense of where the inefficiencies are, where the inequities are, because sometimes health spending is simply not fair in the distributional aspects. And then you can get into questions around cost effectiveness. Where are your priorities? What cost-effective interventions are you promoting? And then to support, the government in thinking what kind of partnerships could be developed with the private sector. Yesterday, Thomas and I were talking about the fact that maybe some of the old models simply don't work anymore. So in the past, you've had like drug donation programs, ivermectin by Merck, and then you have CSR kinds of initiatives. But now probably needs a more sustainable business development model that could be promoted to essentially assure greater access to essential drugs and essential also medical, technologies that are needed to address this challenge. So overall, I think the World Bank can support in thinking about how to use the scarce resources as much as possible in the most cost-effective way, and then how to mobilize more resources.
We'll come on to the question of the CSR-related aspects of the way in which pharma companies work with governments. Can I just ask you very briefly, insurance? What role does insurance have to play in this process, and private sector insurance? Does it have a role or not?
So I think insurance in general has a tremendous role to play. Because you need some kind of function to pool risks. And pooling risks at a large level is better than pooling risks within small schemes here and there. So general taxation, for example, performs that function. You are getting contributions from the population and then spreading that money and purchasing healthcare services for patients within a country. So our view in the World Bank is that the larger the risk pool, the better it is, because it becomes more efficient. So you could have private schemes here and there, but generally, as I said, the broader the mandate, the more efficient it becomes.
Thank you very much. Let's move to Professor de Cruz, Anil de Cruz, who's the director of the Tata Memorial Hospital. There's a fascinating multi-sectoral arrangement that you're working in the state of Assam. I wonder if you'd just start by talking a little bit about what that is and how it came about.
The northeast region, Assam's a state in the northeast of our country, high incidence of cancer. And here this initiative have come from the Tata Trust. The Tata Trust, the Tata Group is well known to us for the Jaguar, the tea, the steel plants, the hotels. And in their philanthropy, they've put this unique model in place, adopted the state of Assam. And basically what is envisaged is a network of various treatment institutions that are digitally connected and would help give access to cancer care for all. Now, this is a 4-tiered system where the highest center, that is the L1 centers, will have apex centers that will give tertiary cancer care. And then you have the L2, which are oncology units within medical colleges. The L3 would be, again, a daycare and other centers which would be part of district hospitals. And then the L4 would tie up with the government primary health centers and spread awareness and early detection. So this is a model that's unveiled. Some of these are greenfield projects, and some of them are add-ons to already existing facilities. The impact of this is supposed to decrease the incidence of late presentations. Now, more than 70% of people present with advanced stage. Hopefully, when the whole model's in place, we would have the other way around. It would just be 30%, and 70 would come with early stage disease.
There are quite a number in India, as I understand, quite a number of these models or similar cancer-related models being rolled out across the country. How is it you decided that this would be the most effective kind of model, and do you calibrate the other models that are going on? I've heard of models in breast cancer control, in Hyderabad, for example, in Kerala around palliative care. I mean, a number of different kinds of models that are evolving. I mean, there's a complexity to that, isn't there? Because, well, India is, of course, a complex place, but the challenge is that there are a lot of new models evolving and being tested and tried. Is there a way of trying to understand which ones are being effective and which ones are perhaps not, and how to move forward out of that?
Ironically, India has had a cancer control program from 1984. And it had all the elements of a perfect cancer control: augmentation of healthcare facilities, early detection, prevention, pain and palliation. Yet, we have an incidence to mortality ratio of 0.66. That's out of every 3 people with cancer, 2 would succumb with the disease. And that's because efforts were placed in setting up regional cancer centers, and they primarily had radiotherapy units. I think people have now realized that that's not the right way to go, and you must have this multi-sectoral partnership. So you're absolutely correct. There are various models together, but I think a model like the Assam model and various other models look across the entire spectrum of control of cancer. That's the prevention, the early detection, and I guess that's the way to go. That will show results. Now, which is going to be the most effective model? We are getting these models in place. Till we have numbers, then you'll know what's more effective. But conceptually, it seems attractive, and this is what's going to impact on the early detection and probably improve outcomes as well. I'm sure you're aware of a new funding scheme that our Prime Minister just unveiled a month back, called the Ayushman Bharat scheme, where about 40% of our population will be covered for 500,000 Indian rupees. In terms of dollars, that would be about $8,000. And this would cover care across both secondary and tertiary procedures as well. So that itself, again, would help people go ahead and complete treatment. We have had smaller schemes like this in various states, but now it's being expanded to a larger proportion of people within the country.
I mean, that model, that new insurance scheme is, of course, I'm sure, hugely welcome in India, and assuming that it gets approved by Parliament. I don't believe it's been approved yet by Parliament, but also, I suppose some questions around it must be, to what level is it, to what extent will it be financially sustainable? But certainly that would be a big question. And I suppose the other question must be, what about the other 800 million people in India? I mean, we're looking at trying to develop some level of access and affordable access amongst the very poor, but clearly there are very many others who won't have that access.
So this is something this is just the first phase of the scheme, and slowly the idea is to go and cover the entire country. But having said that, we've got similar schemes running in other states within the country. So the hospital where I am is in the state of Maharashtra, and we had what was called the Rajiv Gandhi scheme, which is now renamed as the Mahatma Fule scheme, where again people below poverty line have been given access to health care and they're covered by the government insurance scheme, something similar to the Ayushman Bharat. Now, just in terms of statistics, we've had 4,000 people who've benefited from the scheme. These are people from the state of Maharashtra being treated at the Tata Memorial Hospital. There are some other problems in these kind of schemes, like there's a lot of paperwork involved, multiple treatments, the packages that government approve for treatment sometimes is not sustainable, like if a lady with breast cancer needs to have targeted therapy, that doesn't get covered. But I guess at least the basic elements of cancer care are covered by these schemes. And like I said, 4,000 people have benefited at our hospital alone in the last year.
I mean, India is enormously complex. We could spend a whole session just thinking about some of the issues that are there. But I mean, I suppose within the context of the structure of healthcare delivery in India, given that 80% of delivery of healthcare is in private hospitals, and the challenges within the private hospitals of transparency, of understanding the pricing mechanisms, and so on and so forth, what is going to be the relationship between a national insurance scheme and the ability of that insurance scheme to manage and measure outputs and performances within the private sector?
So I guess there is a little bit of a tussle, since this is a new thing that's been unveiled. There is a little bit of tussle between healthcare providers and government. And government is putting a lot of efforts to see that prices come within the realm of the common man. Like we do have now price control on most of the prostheses and various other things that are used, price control on various drugs. And like on this kind of scheme, they have price control on treatment. Earlier, when it was private sector run, there was absolutely no control on pricing. As a result, we would have people who could afford would complete treatment, and then the others would not complete treatment. So I guess government is making initiative, and as I say, it's early stages. With time, things will get ironed out, and probably we'll strike a balance where more people will benefit from these kinds of schemes and these policies.
We will watch it with great interest, I think. And it's a nice segue, I think, Thomas, to yourself. Thomas Cueni, who is the Director General of IFPMA, the International Federation of Pharmaceutical Manufacturers Associations. This question of how pharma companies can engage in building greater access is a really important one, I think. Where do you stand on this question?
It really is, and to some extent, I'm often reminded of an experience I had 25 years ago when I was involved in a major study on financing healthcare reform done by National Economic Research Associates in the US. And the Financial Times at that time published an editorial and said, if you hear that pharmaceutical companies come up with a blueprint for healthcare reform, put your silver spoons away, which means you can't trust them. Fortunately, they continued then, but actually once you read it, it should be adopted. At that time, it was major in the UK, Clinton and Kohl. Nobody ever did. That's why 25 years later, we still talk about UHC. And that's why actually our industry, when you look at it, historically, most pharma companies considered themselves as focused on their primary mission: discovery, developing, and bringing medicines to the market. But when you notice that even in areas where you have treatment for 2 cents a day available, like in cardiovascular disease, or 20 cents a day for diabetes quite often, the medicines don't reach the patients. The companies realize that our mission is to make sure that medicines reach the patients, that we also have to engage in the debate about health systems strengthening, about healthcare workers, about inefficiencies in the system. And what we have done over the last 2 years since I became head of IFPMA was really initiate a number of initiatives, multi-sectoral initiatives. I think the most important one is called Access Accelerated. Princess Dina already referred to it. Most pharma companies have the individual access programs. All of them extremely important, many of them having huge impact on individual patients. What's new is that 24 companies have come together, mandated by the industry leaders to act collectively, team up with the World Bank, team up with UICC for the City Cancer Challenge, work with PATH or the NCD Alliance, because we understand that none of us on its own can have enough impact. And what I think we have realized over the last 2 years is the sum of what we can bring to the table collectively is much bigger than what 24 programs individually would do. Because when you look at what happened last week in New York, I was many years ago a young multilateral diplomat. I didn't consider these meetings as jamboree, as Dr. Prince says. No, I thought it's simply a circus. And to some extent, a circus it still is when you were in New York last week. We need to have a reality check. And I think we need to have some honest talk about what can be changed, what will be changed. We have made great progress over the last 20 years in communicable disease. We had the Global Fund on HIV/AIDS. We had big progress in immunization. I can't see the next Global Fund on NCDs coming up. Since that's the case, we need to look into 2 areas. One is healthcare financing, and the reality is if you have in developing countries 60% of medicine spending out of pocket, in many of these countries even 20 cents for per cost insulin is too much. Therefore, we need to make progress on UHC. And the reality check also means that when it comes to cancer, and here we don't talk about the 20 cents per day treatment, we need to think beyond the UHC. We need to be open about flexible approaches, about innovative funding mechanisms, about maybe impact funds, a mixture of donations, funding, private investment, and we need to make the investment case to invest in cancer treatment. I would try to draw an analogy which I learned from Tim Evans. When you look into the burden of hypertension in China, I understand there are about 300 million hypertension patients in China, actually most of them undiagnosed, most of them not well treated. It has an extremely negative impact on competitiveness, on economic growth. Therefore, investing in health, be it in immunization or cancer treatment, is investing in growth. And therefore, what I see from an industry point of view, we also need to be honest. Historically, most of what companies did was CSR, was donations, and occasionally when you listen to some of our CEOs, you had the feeling it's like the Tata Foundation. You know, we are NGOs, we are charities. If we want to have this sustainably, there needs to be win-win, and there needs to be a sustainable business model. And I think there also from the industry point of view, I do not want to fudge the affordability question, not at all. Because in particular in cancer, diabetes, hypertension, you have very cheap treatments. In cancer, I could for days argue that unless we tackle all the multiple barriers, the lack of healthcare workers, the inefficient supply chains, we will not make progress. But we really need to engage, and if we want to engage, and I pick up something which Dr. Princess Nono said, and I liked her passion there, I see in our companies many thousands of people who are keen and proud when their companies engage in these activities. And if we want to engage, we need to leave our comfort zones. It's easy, for instance, in Geneva to remain in the trenches of ideological warfare. I'm dialectically quite well skilled and would happily engage in that, but that's not good enough. That's why, to conclude, my introduction, over the last 18 months, we have initiated a number of very concrete, down-to-earth initiatives. We are a strategic partner of UICC and the CCAN Cancer Challenge. I must say, over those last 20 months, I've come to respect and appreciate the work done by Carrie, by Sue Henschel, Isabel Mestres, and others. I've been proud to share the podium quite a few times with Princess Dina, and I'm proud to now be a member of the board of directors. Second, we recently co-hosted with WHO and UNICEF a workshop on supply chains. In the US, supply chain markups are on average, I think, of 12 to 15%, which means highly efficient. When you look at diabetes, for instance, per cost given in Kenya by one pharmaceutical company, by the time it reached the patient, it cost 5 or 10 times what the ex-manufacturing price was. On top of that, huge problem, we talked about it, for instance, here in Southeast Asia, people pay out of pocket, and half of the medicines they get quite often are fakes or substandard falsified. Therefore, bringing in our expertise to tackle the inefficiency, and the inefficiency means procurement needs to become more efficient. I've recently shared a podium with Arni Purushottam, who is very much involved in your Assam project. It will be tough, but volumes should probably compensate for much lower prices. We need to find ways and means to address the affordability issue. We have also, in this context, last Tuesday, I co-launched with Francis Gurry, Director General of WIPO, an initiative called Pat Informed, which puts in the public domain information on patents of small molecules. And we learned from a procurement agency that they expect that their procurement processes will be up to 30% faster, which means many more patients will have much faster access to our medicines, which means we need to be willing to engage and not say we wait until everything else is addressed, but really play part and also be held accountable for that. That's why in our Access Accelerated, we asked Boston University to look into, do we make a difference or not?
Thomas, I want to come back to one or two of those points a little bit later, and I'm conscious that, say, a discussion around global funds and different kind of broad funding mechanisms is a live discussion, and Eamonn, you're going to be taking that up a little bit. But just one quick question: the sense that pharma companies are moving from this access question, moving that from their CSR portfolios into their wider business discussions. I mean, I think there would be quite a lot of how do you make that sustainable as a business proposition? Quite a lot of skepticism in this room that really is happening, and that drugs remain far too expensive, and that there aren't really clear and good mechanisms collectively to ensure that differential pricing really is working, because still many countries don't have access to most of the drugs. So how are we going to accelerate that?
Happy to engage on that, not just here, but also during coffee break and others. I think one of the elements is we can differentiate in terms of where the appropriate role of pharma companies is. We are not, in there for rule setting or policy decisions. There, one can easily address conflict of interest and avoid it. But in terms of actually how it's done, I've recently been in New York in a number of the TB meetings. When I look at the multi-drug resistant new TB drugs, what you need is political commitment from governments. For instance, South Africa has really invested political capital and helped to fund the bedaquiline to make sure, and that's where companies can play a bigger role than just being suppliers, because you want to be sure that these drugs are only used in the appropriate circumstances, that you do check that it's certified hospitals, because if you hand it out freely, you will have fast resistance build up. There's big concern in antimalarials, for instance, when you look into the resistance build up. Therefore, the issue for us is about we need to accept that differential pricing requires that rich countries accept to pay significantly more than poor countries, but also that countries actually do invest more. I think it was almost 20 years ago that the African countries committed to the Abuja objectives, 15% of the budget on healthcare. I think there's one of two has met it. When I listened to the Mexican statement, I was in Mexico City in February. Mexico spends 5.7% of the GDP on health. Brazil, for instance, spent 8%. Most industrialized countries spend 12%. It was simply not on the political agenda of the presidential election because the agenda was security and corruption.
Well, let's come back to some of those issues. I mean, they're not all germane to what we're trying to discuss around multi-sectoral arrangements, but some of them are. But let's come to Eamonn Murphy, the Regional Director for Asia Pacific for UNAIDS, and see what sort of lessons are there for us in cancer out of the UNAIDS, or rather the HIV/AIDS process, which was very, very interesting from a multi-sectoral point of view, wasn't it?
Thanks very much. And firstly, if I could thank Dr. Nono for addressing some of the linkages between cancer and HIV, because we're often asked more and more UNAIDS engaging in discussions around UHC, TB. How do we look at the models that have been applied and the investments that have been strong and well-resourced compared to some other health issues in systems for health? And that's the language we're using. Because often when we say the health system, people think of the Ministry of Health. And really, if we're true about a partnership approach to health and a people-centered approach to health, and that's what UHC in its pure form should be looking to achieve, we need to look at engaging a whole range of partners. A couple of weeks ago, I was with the Deputy Director General of WHO, and we were meeting with the Prime Minister of Thailand, and he was looking at NCDs ahead of the high-level meeting last week. And he wants to apply the model of HIV that Thailand was so successful with in applying it to NCDs. Because you need to create demand for both the diagnostics, for the treatments from the community. You need community understanding of the importance of prevention. We need to make sure that the systems of health, community, government, private sector, all different partners engaging the technical, the clinicians, the researchers, the innovators. Digital age is one of the things that we're looking at very closely, and fortunately I was here this weekend ahead of this meeting working with the Ministry of Health here in Malaysia, who is at the forefront of looking at digital technology for communicable diseases and non-communicable diseases. So there's all different partnerships that need to be brought together. And I think the NCDs certainly can look at that model, because I think the reality is we're not going to see increased growth in resources for health anytime soon with the political leadership as it is, as was mentioned from last week's meetings. So we need to look at integration much more. So for us, cervical cancer, obviously HPV are clear links, but there are wider links. TB, Prime Minister Modi has just announced that he's bringing his HIV and his TB programs together. Now he wants to achieve TB targets 5 years earlier than the global target, so that's a major challenge with the highest burden country in the world for TB. But he's using the AIDS model because of that true multi-sectoral and whole of government, but all the systems together working to address it and being resourced. And that's going to be a challenge both for governments to invest, and sustainable is going to be a critical issue with that. So in cancer, we've got plenty of good examples, but we've got to be careful too we don't fragment cancer, because we talk about cervical cancer, we talk about lung cancer, but often the programs from the client side or the community side are totally separated. So how do we get people to understand a bit more holistically and engage partnerships around cancer rather than break it down, because then it becomes naturally siloed or competing, and that's a challenge we have in communicable diseases, so it's no different in that context. There are plenty of examples where strategic information systems have been developed. These are easily turned and applied to other issues. I was pleased to see, forgive my bias for Asia Pacific, I was pleased to see that Myanmar is going to be one of the challenge cities. And they have plenty of good examples, both of investment in domestic investment in health, but also in the public health approach and systems approach. So they could easily apply some of the lessons and the partnerships, and certainly our office in Myanmar would be happy to work with them to look at what could be applied from the communicable disease and HIV model to help support achievement of the challenge for the city that's involved. But the World Bank and ourselves with WHO have done a number of sustainability studies. Now these are issues not just for HIV. In Cambodia, we're working across the health sector. because it's been highly dependent on international support, and that's not sustainable in the current environment. So they're now looking at their investment strategy for a number of health issues, not just for HIV. So we use it as an entry point for health systems strengthening, not in isolation. But so there are in January, the Prince Mahidong Awards Conference, there are going to be a number of sessions on NCDs looking at the models from a range of issues, and we're working with Thailand and Japan on this to look at mother-to-child programs, maternal child health programs, because we know, 45 million women across the world don't have access to ANC programs. That's an issue for cancer as well. So we've got to see how we bring these together. But the models of other programs can then be applied.
I think you mentioned a number of really, really important points. I mean, one of the approaches of multi-sectoral approaches there is clearly to try to draw together enough different types of stakeholders across government and other organizations to be able to create a more holistic approach, a whole-of-government approach, if you will. And the other is really about, with cancer in mind, addressing some of the comorbidities that are arising out of cancer. To what extent are governments, do you think, in your experience, aware of the need now to address comorbidities? You say, obviously, India with the process of TB and diabetes, those two comorbidities are really, really important against HIV/AIDS. To what extent is that conversation now becoming a real conversation and different stakeholders becoming part of the spectrum of discussion around healthcare generally, health system strengthening, but also cancer too?
It's there, but I think we need to do a lot more, and that's where I see UHC as an entry point for discussion. I have a fear around UHC, though, that it'll quickly turn into service packages around treatment only. And if we don't look at investment, if we look at many cancers are preventable. We look at oral cancers in Asia Pacific, and particularly in this region, close region to Malaysia, through betel nut chewing, and the large prevention programs that could be put in place. Diabetes is usually referred to as a treatable condition in many of the countries I've worked with. So it should be preventable. So we've got to change that language. And UHC is an opportunity for that. But I do have a fear that there's not enough energy in talking about that truly public health approach to both clinical care and preventive care and how we bring those together. And that's going to be the challenge for all the partners. The leadership of Dr. Tedros is very clear. He wants to make this a major issue. Michelle Sidibe, my boss, asked me to attend this summit because he's committed not just to the cervical cancer global action, but also to UHC, to make it truly a public health and an integrated, multi-sectoral, not just multi-whole of government, but the other sectors, private, community. Because we can't underplay, one of the greatest successes of getting HIV on the agenda was the community themselves. So communities affected by cancer need the opportunity, and this is a challenge for governments, it may be where the private sector, because they create the demand for treatment and diagnostics as well, for advocacy and challenging all of us to do more and do better and not business as usual. That's where the critical success factor is the community, and so we need to invest more in our community partners who often create difficulties for us, but that's the critical success that we had in Australia when I was head of communicable diseases and HIV. It was our community partners that were resourced to challenge us and challenge the political leadership.
I wonder if we can just pick up that point that you've been making about the sort of the risk that universal health coverage becomes more about the treatment than about the prevention, and the sense that there needs to be a really clear focus around the prevention. I wonder, Paula, if I can just come to you and just sort of ask you your thoughts around this as you begin to build your, and sorry I've left you out of the discussion so far, but begin to build your national cancer control programs in your region.
It would be fair to say that for us in the Pacific, primary health care and prevention is still the key measure that we need to adopt for reasons that would have been clear from my discussions earlier. And it's encouraging to see in the Pacific the discussions about what's happening in India, that a lot of the Pacific countries are looking at primary essential health services and what is available, what should be available at the different levels of healthcare, and incorporating non-communicable diseases. And I think it's an opportunity to be putting in cancer prevention issues as well. Screening is, as you know, is very difficult. So, but I totally agree with the notion of prevention, and in the Pacific, it certainly is the focus. It doesn't mean that we don't focus on health system strengthening and treatment, of course. But by and large, we find it difficult to do treatment because of cost. And as an example, normally we used to send patients to New Zealand, Australia. Now we're sending a lot of patients to India because of the cost implications. And so, you know, if anyone's listening and you want to pilot an affordable, innovative approach to treating cancer in the Pacific, talk to me after the session. We'd be happy to have a discussion on that.
There you go. There's the invitation. So see him straight at lunch. Anil, can I just sort of come to you and just sort of say, well, your approach clearly in Assam is designed, as you said, to sort of downstage cancer, to get in early and to make sure that it can be treated and detected and treated early. But looking at the wider picture and India's program effectively to put in place universal health coverage, what do you feel? Do you feel this sort of balance between, you know, what Eamonn was saying, the balance between the need to really understand and put in place the preventive side of it as much as put in place the treatment side is something that the government is clear about?
I think I would endorse what's been said around the table, and it has to be a holistic approach. Most of the packages that we do have now are targeted purely on treatment. And we used cliche terms like prevention, screening, but to put that kind of a program in place will take years. Like I said, we've had a cancer control program from 1984. We don't have a viable screening program across the country in 2018. So it has to be holistic, the diagonal approach to healthcare. It should be integrated, just as you said, the TB, HIV model. You can't do cancer as a silo separately. It all has to be the primary healthcare, treatment of non-communicable diseases, cancers, everything has to come together. And when we look at insurance packages, I think a part of the insurance package should be allocated to prevention. So you have people who are entitled to a certain amount of money, but 20% of that is allocated to the screening or the prevention. This is just a thought. And then only those that comply with that part of the package are entitled to treatment. Then you get your cancers at an earlier stage. Treatment need not be as aggressive. Treatment times are shorter, and maybe costs are cut down as well.
I think insurance does have a really important role in trying to push and prompt better behaviors. But from a holistic point of view, whole of government point of view, I know the World Bank is very, very focused on this particular approach. What do you see as being the key tenets of that, and what are we going to take away from this discussion about what needs to be put in place in relation to universal healthcare, whole of government approaches?
Yeah, I think governments have a tremendous role in trying to get everyone around the table. They have a great convening power, so they can reach out to CSOs, NGOs, private sector, international development organizations. And I think the focus should be, and this is to get to the affordability question that Charles was, or Thomas was raising, how you can use the scarce resources you have in the most effective way. And this is where cost effectiveness comes in, looking at the best buys and getting the biggest bang for the buck as much as possible. I think to the extent that governments can do that, I mean, just look at tobacco control. I think it's very clear what should be done. I don't think not everything is being done, and their governments and advocates around the world can do much more in that respect. And if I could also just say, Charles, going back to two things related to healthcare financing. I think what we're going to try to do in this report that's coming out in 2 weeks is tie NCD policy to economic policy and say to the leaders and the finance ministers that whatever you do on NCDs that is effective is going to be good macro fiscal policy at the end of the day. And also just to go back to this question of procurement and purchasing, I think this is tremendously important because whatever resources we can mobilize in the days ahead, and I think there is a lot of room to mobilize additional resources. I mean, when you look at other public expenditures around the world, and this is not the World Bank, but it's me saying this. I mean, you look at weaponry, what is being spent on the military around the world. There are opportunities to mobilize resources, but then on the other hand, you need to spend them efficiently. And one of the biggest insights, I think, of health economics over the last 40, 50 years is that medicine is not practiced all the time based on medical science alone. It's practiced based on external incentives. And that's why modern payment systems came into effect. And I think we need to think of how modern payment systems can be used effectively to make sure that the amount of money that's available is well spent.
I think you raised an important point about trying to widen, and I'm sort of imputing what you were saying, but trying to widen the group of external stakeholders in health, if you want to put it that way, in that multi-sectoral engagement that is necessary. And I think, Thomas, you and I were speaking about this earlier, about the need to bring in, just for example, the food sector, the drinks and the food sector, the beverages sector, the sense that there is a huge amount of work that could be done with them to engage in health. And your thoughts just around that?
I fully agree, Charles. And basically, when I look at the debate, I have to admit, I was born an optimist, and the best book which I read this year was late Hans Rosling's Factfulness. It shows how much progress we made over the last 50 years in healthcare. And when we look at best buys, it's actually maybe surprising that the pharma industry person supports public health interventions and best buys, which by and large are about tobacco control, about healthier diets, because if you want to have sustainable resource management, we need to make progress in prevention, and we need to address dietary and other restrictions. I was very much impressed in Montevideo last October, what I heard from a number of Latin American countries, certainly champion being there Tabare Vasquez from Uruguay, in terms of how they tackle it, because one of the challenges, and Firas mentioned, is we need to tap into additional financial resources. And UHC, in countries where 2/3 of the economy may be informal, is not quite as simple as it was in Germany with the Bismarck model, or in the UK with Keynes and Beveridge. Therefore, you need to tap into maybe other ways of taxation. I do believe that we not only need to talk to, let's say, enlightened food and beverage industry, but also you need to bring in insurance companies, because I think insurance and the willingness to buy complementary insurance to top up can play a role.
Well, I think it's been a fascinating discussion so far. I want to turn it over to you, to the tables, and get you to think a little bit about some of the issues that have been raised here, and have an opportunity around your tables for the next 5 minutes to discuss some of the issues that have come up around this panel here, and also to think about any comments or observations or indeed questions that you might have for members of the panel. So we're going to turn off our mics for a short while, and you are going to have an opportunity just for the next 5 minutes to just digest and discuss this around your tables, and then hopefully come back with some questions. So let's begin that 5 minutes now. Thank you. Hopefully So, ladies and gentlemen, if we can get back to the conversation, I'd very much like to, we have microphones placed around the room. I'd very much like to hear from the audience. We have one hand up already here. Thoughts and observations, questions, please. What's been coming up at your tables? Down there, please. Could you just put your hand up again? I think it was...
Excuse me.
I can't...
Here.
Oh, down over here, sorry.
Yeah. Shall I start?
Yes, please do.
Yeah. Thank you. Myself, Lalit Gandhi from India. I representing Global Cancer Charitable Foundation's Mission Cancer Control India. The country which has a 1.3 billion population is almost 20% population of the world. The country is the second largest tobacco consuming country and fourth largest pesticide consuming country. We have daily 2,000 deaths of cancer. I don't know the exact figure of premature cancer deaths. The country having a very huge population, but the 50% of our rural area doesn't have basic medical facilities. We just started mobile cancer detection center 4 years ago. The well-equipped bus having mammography machine, biopsy machine, digital X-ray and all other equipments, latest CBC machines and all these things. We move around the country. In last 4 years, we screened almost 82,000 people entirely free of cost. Out of that, 70% of women, we screened for both breast and cervical cancer. We detected almost 1,185 cancer patients. We got very good support from Dr. Anil Cruz at Tata Hospital. Many of the patients we sent to him got a proper timely treatment. I appreciate UICC having a theme of cancer treatment for all. Most of the people in our country afraid to get screened because they cannot afford the treatment of cancer financially. That's why we are doing the screening entirely free of cost. What we expect from you all sitting here, we need some technology support, the latest inventions in technical grounds for screening mammography, cervical cancer and other cancers, which can be fitted in our mobile units. That's the only source for preventive checkups in India to cover entire country. As the huge country, though the current government is doing various activities to cover this area, but still it is the backlog of 7 decades. The prevention through this mobile center is the only solution, what I feel, in our country. We expect some support in case of technology, and if we get some latest machines for this type of activities. Thank you.
Thank you very much, Mr. Gupta. A call for support, technical support, I think, very important one. Can I come down now? There was a question down here, please. Yes. And I will come to this side. Any hands up here? One in a second. Yeah.
Hello, good morning. I'm Fatima Lorenzo from the Philippines, but I'm representing the very diverse table here on this side. And we had some discussion and we came to 2 points: that we should stop the perception that there is no money, because there is money, it's just not prioritized into cancer, and that we should innovate and think out of the box and maybe learn from the private sector of how to be creative in addressing cancer from beginning to end. Thank you.
Thank you. I'm going to come down here, please, and then we'll come back to this side as well.
Thank you, Charles. I'm involved in the Assam program. I just want to add something to what Anil said. I'm Ani Purushottam, based at King's in London and the Tata Trust Cancer Program in Mumbai. The success, or the potential success of that program, is based on a close partnership between the Tata Trust and the state government of Assam. Without the state government of Assam, we wouldn't be able to do this. They are putting in 50% of funding into the program, and that'll make it sustainable for the future. The second thing is we are developing an ecosystem which starts from health promotion, cancer awareness, right through to palliative care. It's not simply infrastructure buildings that we put in, because that won't address the need of patients for the future in terms of early detection and moving the stage of diagnosis to the left. So those are my two comments. My question is for Firas. Interesting that you're linking your NCD policy to an economic policy, a government economic policy. Governments don't stay for long in many countries. How do you square that circle?
Thank you.
You raise a very important point, and that's how to ensure continuity in long-term or even medium-term policy making, given democratic change that we see around the world. And I think everyone grapples with this challenge. One way to do it is to try to ensure that it's embedded in higher councils, long-term development planning, and to ensure that investments are going in at that level. But it is always a concern. You don't want to make this issue, the pet project or the flavor of the month kind of. You really want it to be part and parcel of the long-term development planning and the macro-fiscal thinking. You need to get ministers of finance who are responsible for the macro-fiscal frameworks of countries to think about how NCDs will be affecting the fiscal position of their government. Because as I said, NCDs will be affecting households, companies, and budgets of governments going forward if left unchecked. And that's why I think they should be prioritized.
Thank you. Yes, just behind. We'll come to you. And any other hands down the side? Yes, over here. Sorry, we'll come to you in a second. Thank you.
Thank you. That was an excellent panel discussion. Many important points. I'm Dr. Shankar from India. Two things which requires attention is integrating cancer early detection prevention services in primary care. Actually, this is one of the weakest areas in health services in many countries. In fact, there is no thinking at all in health services in how to integrate cancer prevention services, early detection services like oral visual screening, visual inspection with acetic acid, clinical breast examination, introducing breast mannequins in primary centers where people can feel and then assimilate, what is the concept of a lumpiness of the breast lumps, because people don't have concepts. And then similarly, providing, vaccination services for those people who are out of school for adolescent vaccinations, like boosters of hepatitis B, HPV vaccination, these are all which needs to be. And then reorienting primary care practitioners and nurses. This is, if the referral system has to properly function, and this is a very critical step, reorienting primary care practitioners. The second thinking is, you can develop health services, you can put infrastructure, cement and mortar and equipment and things like that. Where are the people to man them? The human resource development has considerably lagged behind. And if you take Africa, you can go with $1 billion there. And then where are the nurses, the oncology nurses? Where are the radiation therapists, medical oncologists, surgeons, even to do basic cancer surgery? So this is the human resource development has considerably lagged behind, and it has received very little attention. It is very surprising actually. How the universities in Africa have fallen behind in not introducing faculties for training such people. So this is another thing. But on the other hand, just some of you said, to put successful on the top of the successful program, the only reason cervix cancer screening in the way of VAA screen and treat was possible in Africa only because they used the HIV care infrastructure. It was put on top of that, and that is how it went through. So now there is a lot of focus on TB programs, and tobacco and TB is now linked. So the tobacco control programs, joining with TB, these are some of the things that we need to talk about. And then finally, I think I've been in this field for about 35 years, and we have made some progress. There is no doubt about it. But so much talk has been going on. And in the talks, one of the things, people always think for external resources, service cannot be provided by external resources. Services can be only provided by national resources. Unless locally people work for, bringing, healthcare as part of the political agenda. Not only, I'm not talking about cancer care, healthcare as part of the national agenda. And then having the means to have time-scaled implementation of vertical investments into health services. This is not going to happen. Because we are trying to horizontally expand things, add on things on services, without putting any money into, in a systematic manner into health services. Why some of the countries like, Thailand, I'm very impressed with Thailand, the way that people have done. Healthcare financing is taken into consideration, building up the primary care infrastructure is taken into account, and secondary care centers, tertiary care centers, kept in a very neat condition so that people access and word of mouth spreads. All these things are important. We talk about awareness. When we talk about awareness without creating the type of necessary infrastructure to meet the demands, to meet the expectation, and it is going to backfire. Thank you.
Thank you very much for those comments. Very, very interesting comments. I just want to pick up briefly on that because we were having a chat about this earlier, and that is the sense that, a country like Thailand, I absolutely agree, has done some marvelous, marvelous work in trying to draw together the spectrum of health. Looking at, just from an NCD point of view, at NCDs, not just cancer, trying to think about the integration of that. I wonder, and I'm maybe just coming to Dr. Anil, I mean, here, obviously the program in Assam is very, very focused around cancer itself, but there is this opportunity in the creation of legislation, as I think you mentioned, and in the creation of the framework for health and health delivery to address a slightly wider spectrum around NCDs, is there not? Or is that just not part of that challenge, do you think? Maybe you can both comment on that.
Ani, would you like to respond to it? But I remember when we did have a conversation, initially it was focused purely on cancer. Yeah. But I think the broader plan is to integrate all the NCDs, and that's exactly what we were talking on this side of the stage as well during the break. But maybe if Ani wants to chip in a little bit into that.
Quickly.
If you come up.
Join us on.
So while this is a cancer care program, it's undoubtedly going to expand into a medical ecosystem because facilities can be shared across the board.
Thank you. Well, let's come to down there, please. I know you've been waiting for a thought or a question.
Hi, Elie Kazouf from Quebec, Canada, medical oncologist and hematologist. So I want to address the question, particularly to Mr. Cueni, but thank you all for the insights. The things that stand between a patient and access to a new therapy is actually three things: the approvals, the access, and then the reimbursement. I can see that it was really well approached. The acceleration of the access to new therapies and approvals in different countries have been really faster than it was before. But we are struggling with reimbursements, and reimbursements are usually mainly based on two things. One, the cost of drug development, which is really increasing, and the economic state of the country. So what is actually your strategy to attack this, especially the reimbursement in less developed countries?
Ooh, who wants to take that on? Our friend from IFPMA, Thomas.
That's an easy question. To be honest, we all struggle to find the right solutions, and there's no one-size-fits-all model. What I see is that in developed countries, a willingness of industry to move into new models, such as paying for outcomes, because traditionally you paid per pill, per pack, per injection. And I think there is a move towards, and we see it, for instance, early entry agreements. We see a willingness of industry really to speed up. In developing countries, it's even more challenging, but I've heard about interesting approaches where you do talk about, for instance, a overall package. I know that Uruguay, for instance, has had discussions on breast cancer in that area, and I do sense a willingness of companies to really sit down. But one has to understand this is something which has to be done in countries. There may be some regions where in terms of procurement, like AMREF, for instance, in Africa was recently charged to lead a more efficient procurement, something which I find very encouraging and interesting, but you can't have one size fits all. And second, you need to combine it with UHC, because if you pay out of pocket, you will have very few people who really have access, even if the industry is willing to move a long way in terms of differential pricing. In particular, since I do not expect that we will have the Global Fund for Cancer or the Global Fund for NCDs. Therefore, one really needs to mobilize. One interesting approach which I've heard is in China. One company, for instance, has teamed up with several provincial governments, similar to what Arnie mentioned for Assam, and they offer complementary insurance against cancer care. That's why UHC on its own, in my view, is unlikely to do the job for cancer. We need to be creative, we need to be innovative. I've heard, for instance, from the president of the ICRC that they are teaming up with private banks to issue social impact bonds. I think we need to think out of the box. The industry is willing to think out of the box.
Particularly where funding is limited, yes. Come down here and we'll come down at the end there. Sorry, yes.
Yes, thank you. My name is Naji Al-Sagir from the American University of Beirut. My colleague from Australia here asked me what are the problems, main problems in Lebanon. And I said we do not have a good cancer control plan. Like a lot of countries, we do not have a good cancer control plans. A basic thing, I always like to go back to earth and talk about basic stuff, smoking. A lot of people still smoke. We've been talking anti-tobacco for decades, and I think we have failed. We saw the GloboCan, we saw Dr. Bray's GloboCan. Lung cancer is still #1 mortality incidence. So I think we have to go back to earth, think back more innovatively how to invest in stopping young people, young generation from starting smoking. Hopeless, probably many smokers to quit. But we have to think how to really stop young people from starting smoking. My government pays a lot of money for immunotherapy. Whoever does not have money now, we pay a lot of money for immunotherapy for lung cancer. Billions of dollars are being invested in immunotherapy for lung cancer. We should be able to do a better job in fighting tobacco. And it is a priority, I think.
Thank you, I totally agree. Down, absolutely, I think that deserves a... Down at the back there, sorry, yes, thank you.
Okay. My name is Dr. Abubakar from Medicaid Cancer Foundation, Nigeria. The discussion that came up on our table is that we have all agreed that part of the success stories that come from the developed world stem out of the awareness campaigns that have been ongoing and all that. But when we look at it in the developing countries, the awareness campaigns, what it does, because we don't have the existing structure to support the care for those patients that come out. There's identified increase in the statistics of incidence and prevalences out of this awareness campaign. So what we said, is there any plan, has it been done in the past to try to catch the young population in the education sector, to incorporate it in the overall program and plans that we have in the world? Has it been done and they've been dropped? Because from all the discussions we've had, nobody has said, let's incorporate curriculums in our schools from primary to secondary to university to make it, to increase the awareness in the young ones, which is going to translate in the future as the positive result. But that's the question that we want to pose, that if it is possible to incorporate it, or it has been tried and felt it's not as efficient or as effective or beneficial.
An excellent question, and I wonder, Eamonn, do you want to give that at least a go at an answer?
Thank you. Yes, my background is health promotion, and so the question is well put. Health literacy is one of our challenges, and it has to start in schools. Health promotion, health promoting schools is an initiative in many countries. There's a whole range of opportunities, but it's still a challenge as part of that multi-sectoral dynamic, but it's still a challenge to get ministries of education to put the range of health issues in. So the life skills programs around decision making are part of it. There are a number of good examples that are out there, but it's a real challenge to be able to get that comprehensive nature. But if we take that slightly broader approach, so like if we take an NCD's logic to health promotion, it can address many different issues. And then each country obviously will have specifics, but certainly investing in it has been one of the strengths for us, both in delaying onset of risk behaviours in HIV, but also then helping people understand how to protect themselves.
If I can add, Charles, as well, I think one of the fundamental insights from public health is this multi-sectoral, determinant factor. You have so many sectors outside of health and outside of healthcare affecting health status, and I think one of the biggest ones is the education attainment of the mother, and that affects the infant and child and the health status in a profound way. Well, I'm afraid we have run out of time, and we are heading to lunch. But I just want to give. Oh, sorry, there's a microphone already in your hand. I will just give. If you could make your comment and your question very quick, please, or your comment very quick.
Okay, I would do. I'm from China, the new president of China Anti-Cancer Association. So this is my first time to join you. So as a gastroenterologist and oncologist. So I would like to say something. The most effective way to prevention the treatment of a cancer is to target the etiology. But in fact, but we don't know the exact etiology for all of the cancer. But I think the experience for us is very, very important. For example, in USA, so the 5-year survival the rate is over 60%, but in China it's less than 30%. But now it's more increasing. Why? Because in the USA, the most of the cancer is prostate and breast cancer. In China, it's lung cancer, esophageal, and the hepatic, liver, and the gastric cancer. So my comment is, could we use the experience from US how to control the gastric cancer, liver cancer, especially lung cancer, the experience to use that for the Chinese doctor and so on upside. So in my opinion, the most important way for nowadays is early detection in China. It's an experience. Thank you very much. My name is Dai Min Fan from Terracotta, Xi'an, the center of China. Thank you very much.
Thank you, and a beautiful place too. Well, it's wonderful to hear all of these diverse views, and thank you so much. I'm sorry that we didn't manage to get to everybody. We can take some of those issues up at lunch, I'm absolutely sure, but do please give a warm thanks to Anil, Firas, Thomas, Eamonn, and of course, Paula.